Aloha, Hawaii. It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juleff of the Vein Clinics of Hawaii.
And it's the veinclinicsofhawaii.com. You want to learn that. We're going to direct you to that every now and again. You know, this week's show, and those of you that were with us last time, we had a show called Mailbag. And these are people like you that are asking both Doc's office and me at the studio what you want to hear on this show. And I think it's just great because some of the things that you have asked for just so happens we haven't really covered that much yet. This show has been going, we've been doing this for several months. It's a great show. It's created to educate you on venous disease and all kinds of other things that are, important to your quality of life. Cosmetic things as well. Have some really neat things happening. As a matter of fact, I got to brag a little bit. There was a sort of a little seminar the other night at Vein Clinics of Hawaii, and a lot of people came and just kicking tires and sniffing around and find out what's going on in this place. So that's kind of what we're after. And particularly, we love it when you all interact with us, is giving these questions and whatnot. Pretty good. We had last week's was, I guess, a new way to look at what we're trying to do here, and that is see what people want to know instead of what we want to tell them.
Right.
We have to what a concept.
Yeah. No, I think it's great. Yeah, it's great that people will call in questions and we can address them specifically because it helps individuals.
Yeah, and let me tell you, gang, there is no question to duh. You know what I mean? There's never be afraid to ask a question because every time you think that's kind of silly, let me tell you, Doc has heard a lot more things in the past that were way sillier than that. I think there's a lot of misconceptions about venous disease. A lot of people think it's only cosmetic. A lot of people think it's only if they have a symptom they should go. But, we're going to talk about some of those things today and kick it right off. This is a great one. Doc, you've talked about restless leg syndrome before. And I always thought that was a kid at the mall that was shaking his leg. What is restless leg syndrome, number one?
Yeah, with kids, it's more like nervous leg syndrome.
Yeah,
but,
I should say.
Restless leg syndrome is one of those things, and that's a good question. What is restless leg, and can it be due to, some venous type problem? But the definition of restless leg is really kind of abnormal sensations of the legs. Some people describe a crawly kind of feeling or an achiness, but whatever the sensations are for different individuals, it's a cause for them. It gives them a desire to move their legs, and as they move their legs, then those symptoms are relieved.
Okay, wait a second. You're talking. Let's say that I'm going to go to sleep.
Yeah,
and I lie down, I watch the news, I turn the thing off, and I wait, and all of a sudden, I for some reason my body just turns over.
Yeah,
is that a restless leg that wants to turn around?
No, not so much that. It's a little bit more of just kind of a constant moving of your legs, and I think it probably has to do with muscle contraction.
I know it must cause some marital problems.
Probably.
His leg is shaking all the time. I get up, can't stand it.
Yeah,
stop shaking.
Well,
I'm not shaking.
And there's sort of a spectrum of restless leg. Sometimes, and it does happen particularly when people go to bed.
Sure.
And it's probably because they've stopped moving, and all of a sudden their body is still, and their legs still feel like they want to be moving. So there's a group of people that, just feel that restlessness of their legs when they first go to bed at night. But there are individuals that have restless leg of a little more severe fashion. And, they can have spontaneous movement of their legs in their sleep that might wake them up. Or if they're kicking their spouse, the spouse wakes up too.
What are you kicking me for? What sort of segment of the population does that cover? Is it 50-50? How common is it?
If you look at restless leg just in general, it's about 10% of the American population.
Okay, so 90% of you listening, don't worry about this show. Now we got more coming, believe me.
Yeah, but 10% of the population, that's
a lot of people.
Pretty good number. Yeah. And it's a little more frequent in women than in men, but it affects men and women both. And to answer this person's question, can it be due to the veins in my legs? The answer is yes, because venous insufficiency can be one of the causes or the reasons for restless leg syndrome, which is why, people often come to us.
It must be sort of interesting to you when you meet another doc in another profession, and you're both talking about the same disease, and you both have claim to be able to offer some treatment. So
Sure.
is that the way that is? I mean, you said several things can cause it. So you wouldn't want to go to the wrong fix.
Right. There are a number of medical conditions that can cause restless leg syndrome. Diabetes has been associated with restless leg. Parkinson's disease and other neurologic disorders have been associated with restless leg. Anemia, some medications might cause restless leg. And then, too much alcohol, caffeine, nicotine, those types of things.
That's a catch-all. Too much alcohol is not going to help much.
Yeah.
But I think one thing that comes to mind is that means that, in some respects, I try to be the half-full glass here, that it might be a good thing. That if you know that you have a restless leg syndrome, it might want to drive somebody to go get this. I don't want to be doing this. I don't want to kick my wife. I don't want anybody yell at me. I'm going to go take a look at this thing.
Sure. Yeah. So it's one of those things that we've talked about before. It might take a little bit of ruling other causes out, and then finally getting to what the cause really is. But there's enough people out there that have restless leg syndrome. Enough of them have that, and it can be due to venous insufficiency. So I think that probably if a person has something that they feel is restless leg syndrome and they've tried a couple things and it hasn't helped, then at that point it's time to maybe look at their venous system as a potential cause.
And that's where it comes into Vein Clinics of Hawaii on all 4 islands, Big Island, Kauai, Maui, and here on Oahu. Dr. Juleff and his staff were used to these kind of things. Okay, this is like I said, no dumb question, especially for me. How do you treat it? How do you treat restless leg syndrome?
Well, that boils down to what the cause is.
What the cause is, okay.
So
let's say it's a venous cause.
Yeah, if it's we treat their venous disease, just like we do for anybody else, and we get a pretty good response to it. Looking at all of those people out there with restless leg syndrome, a little less than half probably have a venous cause for their restless legs.
So that's a good number to look at.
And that's a pretty good number of that's a pretty good percentage of all those people out there with restless legs. So again, if there are medications,
I was going to ask you that. We're an instant gratification society, Doc. Yeah. So where's my pill?
Yeah, and we've all heard the commercials for Requip. They advertise a lot on the television. And so that's one of the medications that can be used to address restless leg. But in general, sedative-type medications can be used. Actually, some anti-seizure medications work against or work for restless leg syndrome.
Yeah, but is that, and we come to this junction a lot on this program. Is that the fix, or is it all you've done is cover up the symptom? So obviously, if I got the restless leg and you give me the go to sleep pill, I'm going to sleep.
Yeah.
But have I done anything to really address this other than to go to sleep?
Yeah, you may or may not.
Yeah.
So I think for getting back to which of these patients should come in and have their venous system evaluated, if you've taken a medication or if you've eliminated caffeine and nicotine, etc., and you're still having some amount of restless leg, then that's the point at which you might want to come in and we can address it. And like so many things, it can be due to more than just one cause. Yeah. You might have venous insufficiency and you're drinking too much caffeine late at night.
When we talk about all the things we do on the show, sometimes it takes just forever to pile it up where somebody gets angry enough to want to go do something about that. Is this syndrome, restless leg syndrome, something that people are probably prone to really not look after until it's been a long time and somebody just says either stop kicking me or get another bed?
I'm sure it's one of those things because I think most lay people don't know much about it. I mean, I think a lot of just of the patients that come into our office, many of them have never even heard of restless leg syndrome. So if you've never heard of it, you don't know that it's something that that it is a potential medical condition that can even be addressed. But if it is one of those symptoms that people probably find easy to ignore and put off evaluation for a long, long time.
What are there? What bad effects are there from it? I mean, what further problems could you expect from it outside of maybe it waking you up every now and again?
Yeah, I think that's the main thing.
Yeah.
But
who wants to do that?
But that can be a big deal.
Sure.
It's kind of like muscle cramping that we've talked about before as being related to venous insufficiency. Correcting that in many people, it makes a huge difference in their quality of life. Mm-hmm. Just being able to get a good night's sleep. If they're not because of cramping or because of restless leg, which some people have restless leg to the extent where they aren't getting good night's sleep.
Yeah, and that's the big that would be the big warning sign for me. I mean, during the week, because of my weekly show, my daily show, I need to be pretty much done at 9 o'clock at night because I'm up at 3:30. Yeah. And so if you have any issue during it, whether it's getting up, go to the bathroom more often, or in my case, sometimes if our dog decides he needs to go outside and do his business, it happens at the worst time. It's 2:11. What are you doing? Dog, wait another hour. Yeah. But seriously, there would be a reason to have it looked at, just to determine, is it a minor deal or is it a major deal? Because are there anything that could come out of it that would be major?
I think again, quality of life issues are the main things. Is there any tremendously negative repercussion of having restless leg and not doing anything about it other than quality of life and being able to get a good night's sleep, etc.? Well, probably not that I know of.
Well, here's the thing that comes to mind. There's any number of different ways you can get diseases like sleep apnea and other things.
Sure.
And so, is there a problem with sleep apnea or restless leg? Yeah, if you drive a car. If you fall asleep at the wheel,
exactly.
Yeah, that's a major problem.
Exactly.
Interesting. Now, and by the way, these programs that we're doing now, we're calling mailbag programs because these are a compilation of things that have been put together. Sometimes one segment's not going to have much to do with the next one. And this is the leap of faith that we're going to be taking here because this is probably, and since I've been doing the program, since I met Dr. Juleff, this is the thing that I'm noticing more and more in society and being able to sort of guess what it is, and that is sores on legs and ankles. And it is a huge problem here because we see each other's feet a lot.
Right, right. Yeah, in this question is, I have a sore on my ankle, doesn't seem to be healing. Why is that happening? And it's a good question because, lower extremity ulcers, basically we call it an ulcer. Yeah. There's a number of different reasons why people might have those, and some of them aren't necessarily obvious to the patient. So, when somebody comes in with an ulcer, our first question for ourselves is what's causing that ulcer?
You bet.
And, the big three are either arterial problems, which means that there's not enough blood getting down there. And that can cause an ulcer on the foot, more so than the ankle, but in various parts of the lower extremity. There are something called diabetic ulcers, and obviously we see those in diabetics.
Now, I've noticed a differentiation, though. I think that you drew the line once a few programs ago, and that if the ulcer is primarily below the ankle or on the foot, it probably may not be a venous ulcer.
Correct.
It's probably an ulcer from diabetes or something like that.
Yeah, diabetes or arterial insufficiency.
Yeah, gotcha.
And they all have very typical kind of appearances. And we've sort of talked about it in the past. But when somebody comes in with a diabetic ulcer, it's so specific in its appearance that, you just learn to know that. So arterial, diabetic, and then venous are the big three. So arterial insufficiency, not enough blood getting down. Venous insufficiency, the blood's not getting back up.
Sure.
And that can be also a very common cause for lower extremity ulceration. And there are other things, trauma, various inflammatory kind of diseases, malignancy. When somebody comes in with an ulcer,
Test it.
Sometimes we have to biopsy to make sure that it's not a skin cancer. So we always have to have that in the back of our mind.
And gang, this it comes up a lot. These ulcers come up a lot because, if you've been listening in the past, we'll go over this from time to time. There are like 6 stages of venous disease. Little tiny things all the way up to these big ulcers that we're talking about. And what you said earlier resonated with me, so that we really got to let people know this a lot. Some people will just be absent-minded about how long they've had something, especially if all they've done with it every morning forever is put a little bit of a dab of antibiotic on it and a Band-Aid on it and thinking that's it. And it is for the moment. But if it doesn't heal it after a couple of months or something, or even less than that?
Yeah, even less.
You're not doing the right thing.
Right.
Yeah.
But yeah, you're right. It's amazing how long people will watch something like that until they get sick of it to the point where they're going to look into it. But if an ulcer or a wound anywhere, quite frankly, but especially in the lower part of the leg, if an ulcer or a wound is not healing at about a month, then there's something going on. Or if it's getting worse,
Yeah, that was the other thing. Yeah, I was acting about that. Not just getting worse, but maybe getting larger.
Yeah.
Is that what you mean by getting worse?
Sure,
yeah.
Sure.
So that whole, and it looks to me like, and I experienced one of these things, it was horrific. What got me doing these shows, what got me doing a lot of things is I had a trauma that turned into a venous ulcer that was really a big problem. And until it got solved, it was very disconcerting. And I thought all along that this thing's just never going to heal, and it kept getting bigger and bigger, which not giving the chance for skin to come back over it or any of that stuff, right? It's an open hole.
Yeah, and that's a perfect example right there where, not only is it not healing, it's slowly getting worse, and it can be gradual. It doesn't get a whole lot worse overnight. With each week that goes by, it seems to be getting worse and worse, and I think that's another reason why people can sort of ignore it. But if you look at the whole group of people that have ulcers or wounds on the lower leg, venous ulceration is actually the most common one.
Yeah,
so,
and by the way, let's go back several programs where we had this lady that had responded and reacted fantastic to treatment. And one of her complaints is when she came into your office way back, she had an ulcer that went completely around her leg. Mm-hmm. And that was like, what is that, like a band of wound?
Right.
And I would imagine there's any number of complications that can arise. Although you did say that it didn't automatically mean it was infected. It didn't automatically mean it was going to get worse from the outside. But it sure looked like, how could anybody really even live with this?
Yeah, they can look bad, and you're right. They can be very extensive, not only all the way around circumferentially, but large areas of the calf can be ulcerated and sore. They look terrible.
Yeah. But one thing I did notice, and I talked to a couple of the patients, it wasn't necessarily painful. Mm-hmm. But it was just irritating that it was there.
Sometimes they are, sometimes they're not. Yeah.
I would almost want it to be painful because that makes you go do something about it.
Well, that's true.
Yeah.
But it's funny, after we start treating these things, sometimes people come in and it can be pretty painful to touch or clean. But after we get the treatment started, the discomfort goes away pretty quickly. So anyway, venous stasis is the most common cause for, there's a bunch of wound care clinics, which has been a good thing over the course of the last 10, 15 minutes.
They've popped up rather recently, haven't they?
Yeah. And it's been a good thing, but when you look at all the people that go into a wound care clinic for ulcers of the lower extremities, the majority of those are due to venous stasis. Yeah. So
that's very interesting. So you take a look down. If you've got that thing that's nagging and you didn't think it was a big deal, could be.
Yeah.
I don't want to scare you to death, but I was scared to death for me. I thought, what's the matter here? This is terrible. But see, I thought it was infected. It didn't turn out to be infected.
Right.
But it sure looked it.
Yeah.
Okay, so what are some of the things you do when somebody presents with this ulcer, and obviously they've come to you to take a look at it? Is that the first thing you go for? Are there other things you have to do? How do you deal with that initial guy coming in or gal coming in with an ulcer?
Well, when somebody comes in and we're just initially evaluating them, the question for us is, could it be due to venous insufficiency? And so along with that, we ask them questions concerning the symptoms that they may have otherwise. Maybe they've had longstanding venous insufficiency even before, which most of them have. They've had longstanding vein problems even before they had the ulcer. What does an ulcer really imply? Well, it implies a fairly late stage of venous insufficiency. You mentioned that before. We have to consider, where it is in the anatomy. And, of course, we look at most of these people with ultrasound to define whether they have venous insufficiency and where it is. Often these ulcers are associated with something that we call perforator veins.
Yeah, I was going to ask. Now, I do know one thing. Your veins that go down, up and down your leg are one thing, but some of them go sideways.
Yes.
And that's what you call a perforator, right?
You're right.
And I had an issue with one of those things, which is probably what my ulcer came from.
Right.
And it just happened to be the trauma from the outside and the vein on the inside touched each other. And it created the perfect storm.
Mm-hmm. Yeah, well, and in many cases, in many people with chronic ulceration, that's one of the things in particular that we look for. Is there a perforator vein? Is that perforator vein also not functioning well?
Now, do you have a bunch of perforator veins anyway, or are these something that happen to take over moving blood somewhere where there's an injured vein?
Yeah, no. Perforator veins are part of the normal anatomy.
Okay, so it's normal. Yeah.
And perforator veins also have valves in them, even though they're relatively short.
Yeah.
They're connecting, like you said, the deep system with the superficial system, so they're relatively short. But there are one-way valves in those veins that control the direction it should be going inward, not outward.
So it must be a good idea that you have these, because when in an emergency or shortly thereafter, that perforator can take over and help move the blood that no longer is going through a damaged vein or a vein that's closed or gone.
Well, there's a certain amount of blood in the superficial system, for instance, that will move longitudinally, along the long axis of the leg, but a certain amount of the blood that's going into that venous system is going to go from that superficial long vein into the deeper long vein, and that's normal.
Yeah. That may be good, as a matter of fact.
Well, that is good. That is good. Now, in venous insufficiency in general, the underlying cause is a failure of those one-way valves, no matter which vein we're talking about. Now, in particular, as it relates to ulcer formation, we have just found that the ulcer is often associated with a perforator vein that is incompetent. The valve is not functioning properly, so the blood, rather than going from outside to in, from the superficial to the deep, is going in the opposite direction. It's going from the deep into the superficial. And that's how that increased flow and pressure is having an effect on that one area of skin and soft tissue of the lower leg. And that's what then ultimately leads to the ulceration.
Okay, now that being said, when somebody does come in, like I said, presents with one of these before, I would imagine the treatment is specifically going to go at that symptom first. But what other information do you get out of my leg that explains to me, the patient, why this thing is there and why I need to take a look at some other stuff so that we can either find the next one or not have the next one? Once you get one, aren't you likely? I've been told that I'm likely to have them again.
If you don't have if you don't have the cause addressed, and that goes for anything, whether it's arterial, diabetic, or venous, or whatever it is. If the cause of that ulcer is not addressed, then very likely it will either, number one, not heal, or number two, it will heal for a short period of time and then come back. Now, that cycle of healing and reulceration, healing, reulceration, is a very, very typical scenario for, specifically venous stasis ulcers. So we evaluate the venous system of that patient, and we address all their problems. Now, typically, we'll address we address the superficial venous system initially, and see where that gets us. And then if we, usually it's as a second step, we find out that, or we, diagnose the fact that, a perforator vein is continuing to be a problem. So can those perforator veins be treated individually? Yes,
yeah,
they
that's
can.
what I was going to ask. And then the second thing was that, obviously people want to know, okay, well, thanks for diagnosing me and giving me a treatment program, but how did I get this thing? In other words, what did I do or what was done to me? Why is this ulcer here?
Right. And that's the crux of the problem right there. So we treat their overall venous status and we make sure there isn't more than one, reason why they might have an ulceration. It's always been surprising to me how little there is, the patients that have both arterial and venous disease. Usually it's either one or the other.
I asked about that before.
But in general, we've got to be thinking about both. But typically it has to do with their venous system.
Are there any, for these ulcers, just to get this out of the way, is there just any ointment or something somebody just slather on and get healed?
Alone? Yeah. With no other intervention?
Yeah.
No.
Probably no, yeah.
So
those of you, what I'm getting at, those of you that are out there that haven't gone to veinclinicsofhawaii.com yet or given this a shot, everybody at every clinic, Big Island, Maui, Kauai, and Oahu, certainly has seen enough of these to be able to get you into the system to get the thing diagnosed and treated. Because if it goes untreated, it may just be an ugly thing for a long time, but I'm worried that it would be, after a long period of time, be life-threatening, or be threatening at least.
At least limb-threatening.
Yeah, limb-threatening, that's what I meant.
Most of the time, luckily, they don't come in with infection, but the ulcers, the venous ulceration or whatever kind of ulcer, can become infected, and that's a whole other dimension of problems that you're dealing with.
I got to tell you, and this is no coincidence, I do a program, Hope for the Homeless, quite often on my regular radio show, and I've had the opportunity to talk to Dr. Josh Green, the physician lieutenant governor. And one of the biggest problems in the homeless community are leg ulcers, because they're living in not good conditions, and they have a venous leg ulcer that turns into a nightmare.
Sure. Yeah. Well, they can't be treated, or they can't get treatment, and also their lifestyle is such that it's probably the least optimal for addressing venous insufficiency. I mean, so many homeless people are on their feet all day long. The lack sanitation and cleanliness and all that.
I think mainly the reason I said that is because if your immune system is bad, these things get worse and worse. But what I wanted to then go aside is, when you decide what treatment plan to follow, what expectation can you have? How long does it take to clean up? I guess depending on size and depth and all that stuff. And cause, but for venous stasis ulcers, I think people, once they come into the system and they get treated fully, and we care for the ulcer at the same time, there are certain things that the address, or the ulcer itself needs to be addressed, like you were alluding to before. Is that enough in and of itself? No, we have to address everything, but there are ways that we can help that ulcer improve healing just by local care of that ulcer. I was going to say, the local care of the ulcer is depending on all the magic things that you can put on it, right? It's not just, you can't use that one tube that everybody uses for, you think that's going to...
Yeah, wound care has become a science, that's for sure.
Can you actually cause more damage by using, say, an antibiotic over and over again that isn't closing the thing? Can it cause a problem?
In a local sort of way like that, no, not really. But I think at some point you just recognize that it's not doing anything.
Yeah. And so that plan is out the window. And we don't. But then here's another one. Somebody else asked me this too, and I was actually talking to a guy on the street, this friend of mine, and he's talking to me about the show, and I said, you can see these people that have these things. Just look around. And I'm guessing that quite often you'll see, as a venous surgeon, a patient will come in and have more than one kind of ulcer because they're in bad health. They got the diabetic ulcer on their foot. They got the venous ulcer, 3 inches away on their calf. Are they treated the same way?
No.
Yeah, I thought so.
But they both have to be addressed. Luckily, we don't see that very often. Yeah, luckily we don't, especially diabetic and the other causes. But and it's not very common that people have both venous and arterial. But typically, if somebody does, then we address the arterial part of it first,
okay,
and then correct the venous insufficiency.
Okay, now getting back to our mailbag, let's go move on to. We talked about mom. We talked about a little bit about caring for the ulcers, but one more thing on this. I just saw a note on the perforator. Is the treatment on the perforator ulcer different from because you're not seeing the perforated ulcer on the outside much, are you?
No.
Yeah.
Not at all.
Yeah.
It's something that we look at with ultrasound, and we use the ultrasound extensively over the course of the procedural things that we do for that. Now, is the basic way that we treat that similar to other, endovenous procedures? Yeah. Basically, for a perforator, most of the time we're using heat.
Yeah.
We're using an endothermal approach to it. And we can use either laser or something called radiofrequency, but we're using that heat to cause contraction and closure of that perforator vein.
Does that perforator vein respond better to treatment than some of the open ones? I mean, you sometimes, if you have this thing on your leg that's been there for 4 months and the antibiotic hasn't healed it, you're doing the wrong thing. And I would imagine that the perforator ulcer can also be ignored for a long time unless it's symptomatic. Is there a symptom? Do you feel anything?
Perforator veins? Yeah. Well, in addition to ulceration, people certainly can be symptomatic from perforator reflux. And they perforator reflux adds to just the usual symptoms that we see with venous insufficiency, the achiness, heaviness, swelling, discoloration of the skin, etc.
Yeah, is that a major part of the practice? I mean, I do know that it's rare. Not everybody gets these things, but the ones that do get them, they demand treatment. It must be somewhat gratifying or really good when a patient does get healed, when they realize, boy, I had no idea how bad this was. Now I feel better.
Sure. To answer your first question, it's a minority of people that come in with, extensive venous insufficiency to the point where they've developed venous stasis ulcers. There's many more people that we treat that don't have that. But there's a good number of people that do present with ulceration as their first symptom or their first presentation for evaluation for venous insufficiency.
Well, I can get that. If somebody's had maybe spider veins and treated and whatnot, and their legs look fine, they may never know what's going on inside.
Yeah, right. Typically, that's not the scenario, though. Usually, if people are showing up with chronic ulcers, it's because of long-standing venous insufficiency. It doesn't happen with those lower grades, as we've talked about before. And often it can be part of what we call post-thrombotic syndrome. Now, post-thrombotic syndrome are those legs that have suffered a DVT in the past.
Deep vein from...
blood clot formation. And, just by virtue of having had that blood clot and then the deleterious effects of that and vein function, that can lead to chronic swelling and skin problems and ultimately skin breakdown. So usually, ulceration happens at a late stage in the whole process. So
and by the way, I'm glad you said that, because now that I think of it, I haven't seen any young people with that. I don't know if your immune system is better than others, or the damage inside just isn't the same. But it is something that is probably way more common once you get in that 6 stages of venous disease. Once you get up to 4 or 5, it's going to happen to you.
Right.
Interesting.
And it goes. Age is a factor, but again, age just is a reflection of time. And the longer amount of time that you go with untreated chronic venous insufficiency, the worse it's going to get, and the more likely you're going to enter one of those higher stages.
Okay, so let's jump outside to the lanai and talk about Dad for a while. Dad, and we're talking about, when, like I said, my granddaughter said, "Papa, what is that on your leg?" Particularly, I think, locally, since we're traveling around in shorts all the time, sometimes you see these, big, like, football coaches are out there, and their legs just look really weird and discolored. What's that all about? Because I see that next question is, my father has a lot of discolorations on the skin and his lower legs, and he thinks it's due to diabetes, and there's nothing more that can be done for that. What are the differences between what causes that and if it's a venous deal to treat it?
Yeah, another good question, because skin discoloration of the lower leg is one of those things that people, number one, don't know what the cause is.
There can be a lot, right?
Well, there's a number of things.
Yeah.
But also, it's one of those easy things to kind of ignore for many, many years, And again, it's one of those symptoms that comes on very, very slowly, and it's just a very, very gradual process. And people don't, recognize it the way somebody else, a second party, is going to just by looking at their legs.
Well, I mean, but there's a visual look that it has.
Oh,
but
yeah.
There's also a physical feel that it has. In the case of me, I got this skin that's a little more leathery around my gaiter, that lower part of my leg.
Right.
And I've been very patient with it, hoping it's going to go away, but it doesn't.
Yeah. Well, and that's an even a little later stage.
Mm-hmm.
With respect to the stages of venous disease, discoloration, just a homogeneous sort of discoloration of the skin of the lower leg is kind of the first stage of those upper levels where you start to have skin effect. You've gotten into a little higher stage because the skin is thickening and becoming leathery and rough. Yeah. So the thing that we tell people is that no, diabetes is probably not the cause, especially if you have other signs and symptoms of potential venous disease. And venous insufficiency is very much one of the common causes for discoloration of the skin, and that's something that most people don't know.
Mm-hmm. Are there times that your heart is the issue because the heart's not pumping enough blood or enough pressure to get down to your legs? If you have heart issues, wouldn't it make sense that then these other deeper problems further down, obviously if your heart's not getting enough blood to you, the veins can't take it much back. That must mean that whatever's going on there is also affected by the ticker.
Yes and no.
Mm-hmm.
Can heart disease lead to additional swelling of the lower extremities, which would be a complicating feature of somebody who already has venous insufficiency?
Gotcha.
Absolutely.
Already got them.
But does heart failure typically impact the amount of blood getting down there that's going to lead to a problem? No, it typically is not. Unless the heart failure is very, very advanced. But usually with poor heart function, we get concerned more with fluid buildup in the lower legs, which again is going to be an additive to their venous insufficiency.
And I think that you addressed this once before in another program, but and remember, gang, you can go to veinclinicsofhawaii.com and hit the Contact Us button and write a little note. And we'll get it. We'll get your concern aired on the program. And you can also call me anytime. Email me, themikebuckshow@gmail.com, and get your questions answered. Because I think once you've got to that, is there a cure for it, or can you just sort of manage it? In other words, if that skin gets tough and leathery, can it be, like sandpapered off so the better skin comes in, or are you kind of done?
Well, with respect to discoloration, no, it never really goes away completely because it has to do with staining of the skin, and once that's there, it's almost like a tattoo.
Yeah, I was going to also say that don't some people think, well, it's not venous, there's sunburn.
Yeah,
I'm outside like
right.
I'm just sunburned.
And that's another thing that people say all the time. Gee, I work outside or whatever, so that's it's sun. But so what's really happening there with discoloration? Again, it goes back to abnormal blood flow in veins. The blood in the veins of our legs should be carrying blood upward. When the valves fail, the blood starts to go downward. And that creates an increased amount of pressure within the venous system.
It's all about pressure
of the leg. We call that something that we call venous hypertension, just like hypertension everyday hypertension that people talk about. So that downward flow in venous hypertension over a long period of time has deleterious effects. Now, what does that increased pressure cause? Well, as the pressure goes up and is constant, chronically over a long period of time, things start to leak out into the soft tissue of the leg. First, it's just fluid, and you get swelling. But then with time, there are not only inflammatory kind of molecules that start leaching out into the soft tissue and the skin, but also red blood cells.
Gotcha. So it actually looks like it's layered. It sort of looks like the discoloration is in layers. So maybe it's worse towards the bottom, and it comes up and gets lighter. That's what I see. That's what I see on myself. Where the discoloration, it's not all discolored. It's discolored in a range.
That's a good observation, because that's absolutely right. The lower you go down on the leg, the more hydrostatic, basically pressure you're going to see, and you're going to see the result of that more exaggerated. So that's a very, very typical a picture of a person with discoloration. It's darkest in the lower part around the ankle, and then it kind of gradually lightens to normal, mid to upper third of the calf.
Yeah, and that's why I asked the question, because I think that then the next thing that somebody would want to know, and I've heard part of that question already, and that is, can I get hurt there? In other words, this is leathery skin that's, it's really not really working as good skin anymore. If you perforate it or damage it, can it turn into a problem?
Sure.
Yeah.
And the reason for that is because of the underlying process.
Yeah. So in other words, that's what's going to make an ulcer eventually.
Exactly. Yeah.
Boy.
Now, in that skin may or may not be easier to damage than regular skin. Sometimes the skin gets, you were sort of describing, kind of leathery, thick-skinned, fibrotic sort of skin. Sometimes it starts to thin out, and that skin is a little more fragile and more easily traumatized. So, but is trauma a problem in that setting? Yes, definitely, because of the underlying venous disease that's going to then allow that to turn into a much, long-standing ulcerative sort of problem.
Okay, now when that skin gets as thick as it does, obviously it's not good at replenishing itself anymore. What other problems can it cause? I mean, we've already talked about if you get a hole in it, you might end up with an issue. But don't some people have things going on in there that they don't feel, but it's not good? I mean, I don't want to say that stuff is rotting in there, but it must not be getting any nutrition of any kind.
Well, it starts to lack oxygen, retrieval. But I mean, are there other problems? Yes, but having to do with skin, for instance, the skin can become rashy. There's something called venous eczema that can be part of the whole process too. But there's a host of skin changes that can occur. But mainly it's just because in all of those changes are due to that venous hypertension and the leaching out of molecules.
So what I'm guessing here is that when you start getting diagnosed and undergo treatment, that there's a path that you follow for just about everybody that is going to, if not anything, reduce the damage or maybe slow it down a little bit, particularly if there are any moves. And I don't know, are there any moves that somebody can make nutritionally? I mean, we often ask that question, and it seems to come up no most of the time.
Yeah, most of the time, no. It's not like any nutritional or dietary changes are going to have a substantial effect on it. So we want to stop. The reason that we treat is not only to treat the venous insufficiency and whatever symptoms that patient might be having, but to halt the process.
That's what I'm getting at. Yeah.
So is discoloration or in most of those skin changes, are they going to go away even after we treat? Many of them don't. No, but the goal is to stop interrupt this chronic venous hypertension and make sure that the process doesn't get worse with time, which it will if you don't treat it.
Yeah, and that's the thing, gang. If you're looking like this at all, you really need to get seen. And the best thing to do is give one of the branches a call. If you're on the Big Island or Maui or Kauai or here on Oahu, go to veinclinicsofhawaii.com. All the locations are there, and you can click through and get a comment and get an answer and make a suggestion and really just find out. Because I think and this is why Doc Juleff and I are doing this program, and education is the key. I mean, everybody learns a little something every day. As much as I think I know now about, I learn something every single week. This week, it's like, you can't expect to have something turn around and heal, but you can certainly slow it. And that's the key, isn't it?
Well, healing, we could, with respect to skin breakdown and ulceration, we can get that healed.
Mm-hmm.
We typically.
And you mean wound control stuff?
Yeah. Sure. Yeah. But you want to treat the underlying cause, because you don't want those problems recurring with time,
sure,
which is very, very common especially with venous problems with the skin.
Okay, so if that's the case, if you noticed anything, and I bet you there are people right now that are looking down at their legs, or mom is pointing out, hey, Dad, you got that thing in the back of your leg. That's what I think Doc's talking about here.
Yeah. Yeah, well, again, that's one of the reasons why we like to talk about this, because, most people don't know the connection between, lower leg problems and their venous system.
One of the things that we've learned over the course of the program, and a lot of us know just doing basic, cursory reading in the internet, venous disease takes a long time to come on, and therefore, I guess a lot of people kick the can down the road about treatment. Mm-hmm. Because it's not. I'm not talking about the cosmetic part, because the cosmetic part people want treated right away, don't they?
Yeah.
And you said earlier, and I can get this because I had some done. Men are getting a little bit more particular. Taking a look, you see more men that are coming in for a spider vein and surface vein removal.
Well, we do see that, but I think the important thing there is that the venous disease in general is a problem that both sexes have. I think for many years people thought that veins, varicose veins, and spider veins, it's primarily a problem that women have, but not the case. Probably 40% of our patients are men, and they need to be evaluated too, because they are certainly having symptoms. Mm-hmm. Men tend to come in a little later because they tend to ignore every symptom.
And I was going to say, and if it's on the back of their leg, they probably never see it.
Where
mama's a little bit more careful about that.
Yeah.
Let's make sure that another thing. Sometimes when younger people start hearing about venous disease and get all panicky, they must be reaching out all the time and saying, if my mom and my dad are like this, is this me? Is this going to be me?
Yeah.
And unfortunately, the problem, most of the time, a little bit.
Very likely, yeah. If both parents have venous insufficiency, the likelihood of an offspring having venous insufficiency is very high, probably close to 90%, if both patients have significant venous insufficiency.
Okay, how do you determine what is severe? Everybody must have a modicum of venous inefficiency somewhere. But, when it gets to a point where somebody needs treatment, let's again discuss some of the ways that if people are feeling one way, maybe not looking, they just feel bad. Maybe there's something vascular going on. And I know now with the number of primary care physicians that will immediately take a look at something and say, this is for Dr. Juleff. I'm gonna send you to a venous guy. Is that happening, thankfully, a little bit more in the general practitioners sections where they are referring people out to get venous work done?
Yeah, sure. And to answer your first question, when do we decide that it's significant?
Yeah.
And that goes to when do we treat people with venous insufficiency? We have them come in, or they come in, we evaluate them, and then that's one of the crucial decisions that we make.
Sure.
Now, there is tried and true kind of parameters that we look at, and a lot of them have to do with what we see on ultrasound.
Of course.
So when we do an ultrasound, we can see that blood going in the wrong direction. And one of the parameters, for instance, that we look at is how long does that reflux go on?
Gotcha.
So there's a certain time period that then becomes significant. and we detail that with the ultrasound.
Yeah, I actually had this done just the other day. I want to expand on that a little bit because I'm just flabbergasted at, first of all, the new twist that these devices have gone through. They're like Doc said a while ago, they're just like slightly oversized laptop. They spring up, it has this probe coming out of there, they put this ointment on you, and as soon as they touch your leg, you can see what's going in there. I'm absolutely, fascinated by that. And I'm sure that most patients that see it for the first time feel the same way.
Yeah, people love to watch the ultrasound.
Yeah, it really is great. Especially when you know that that's you. I mean, we've seen them on television shows where they're showing a pregnant mommy. They're showing them the baby. That's exactly what you can do, isn't it?
Yeah. Oh, yeah.
What special skills does it take if somebody is looking for a career in that? Because I would imagine that every surgeon like yourself has to have really good ultrasound people working with you.
Yeah, that is no more true than in venous disease. There's no question about it. The process of doing an ultrasound is very operator dependent.
Yeah.
It's when you're doing a chest X-ray or even a little more complicated exam like a CT scan or something like that. You put the patient in the CT scanner and you take a picture.
It does a scan, right?
Yeah. Whereas when you're trying to get information with an ultrasound machine, it is tremendously dependent on the person doing it. And the studies that we do are probably one of the most complicated with respect to, vascular sort of evaluations. Sure, so having a good ultrasound tech is extremely important. I feel very lucky that we do.
Yeah, and by the way, and I met some of them, especially Mike the other day. He was just a great guy. I felt so confident in that he was going to do this discovery. I think it's also important if somebody's going to be moving or if somebody's going to be doing something, that the transfer of records, when you have somebody that's as good as what your guys have been, that the next doc down the road would, boy, this is a welcome piece of the research that I need to treat this guy.
Sure. Yeah, we document pretty extensively.
Once somebody has gone through treatments, and we talk to a lot of dentists and a lot of other practitioners, and the older we get, the more we tend to put things off, and it should be the opposite. When somebody comes in after you've treated them with some vascular disorders, how often do you like to see somebody? Semi-annually, annually?
We eventually get them to about every year coming in for an ultrasound. Yeah, sure. And the reason for that is that since venous insufficiency is a most of the time genetically produced sort of problem, it's not like when the patient comes in, we treat them. We're not changing their genetics.
Yeah, exactly.
They leave the office with their same genetics.
And the other thing that rings true is also, let's talk about how, thank goodness, knock on wood, the insurance companies have been responsive to the tools necessary to do the stuff that you do, knowing that an ounce of prevention, right? If they can get somebody early in a disease of any kind, it's going to cost less down the road.
Right.
So let's spend 1 minute here on the difference between something that is elective and something that is covered by insurance.
Well, those elective just means that it's not emergent.
Okay.
But with respect to venous disease, the insurance companies cover essentially everything that we do that's medically related. Mm-hmm. The only thing that insurance carriers won't cover are things that they deem cosmetic.
Sure.
Across,
that makes sense.
Across the board.
That.
Yeah. I mean, that's perfectly good. And the main vein issue that we take care of that is purely cosmetic is spider veins.
Yeah.
So everything else is covered by insurance, which is good. And yes, I think your point before about the fact that the insurance companies and Medicare recognize the fact that follow-up is important.
Yeah, exactly. Management.
And if we do ongoing surveillance of our patients in an appropriate sort of fashion, we're going to find things early if new things are coming up, and those can be addressed in a much simpler fashion than all of the things that they probably needed before or possibly could if we don't do adequate follow-up.
Yeah, a dermatologist friend of mine once said you have to examine your birthday suit on your birthday. You know, so it's a pretty good it's a pretty good line to say, and listen, even if it's been a while since you've had treatment, It's so good to go in for a checkup. And because of Vein Clinics of Hawaii's presence on all the islands, it is really convenient to do that. So I want you to go to veinclinicsofhawaii.com. That's veinclinicsofhawaii.com and get yourself in on that. And if you've got questions or comments, you can enter there and communicate with us or contact us, or you can send me the MikeBuckShow@gmail.com your thoughts, and we'll put that into a program for you as well. So for Dr. Juleff and everybody at Vein Clinics of Hawaii, I'm Mike Buck. Thanks for being here. See you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.